Hi, everyone. This is Cheryl Fleury from GEM Technologies, and I'd like to thank everyone for joining us today. I'm the Vice President of Marketing, and I know your time is very valuable, so I appreciate you choosing to spend an hour of your day with us. For those of you that aren't familiar with GEM Technologies, we've been around for about 15 years, and we're a company that's been developing cloud-based mobile technology to help organizations with their supply chain management processes. Most recently, we've been focusing entirely on developing solutions for hospitals and health systems. In fact, a few years ago, Jump Tech made a commitment to focusing entirely on the healthcare supply chain so that we could help hospitals improve their supply chain processes. So in this endeavor, we are continually looking for ways to help hospitals bridge the gaps that exist in their supply chain today, as well as bridging the gaps in some of the legacy systems that are in place in those hospitals. Today's webinar will last about an hour, and we will be recording the webinar so that we can send the link out afterwards. You'd be very welcome to share the link to the recorded webcast with your team members. And if you find that you have questions during the presentation, please just send them to me via the chat function. And as soon as there's a break in the presentation or when we get to the end to the Q&A section, I will go ahead and ask those questions of Jamie Kowalski, our presenter today. So let's go ahead and get started. I'm very pleased to introduce you to Jamie Kowalski. Jamie is the CEO of Jamie C. Kowalski Consulting, and he's a well-known industry expert. In fact, many of you probably already know Jamie, who for the last 30 years has been working to improve the healthcare industry. Jamie is a speaker. You've probably seen him at industry events and conferences. He's an author, a strategic advisor, a thought leader, a coach and a mentor, a consultant, and an advocate for the healthcare industry. Jamie's the author of 5 books on supply chain management. He has contributed to 3 others, and he's written over 80 articles that have been published on supply chain management topics. Jamie's worked with hospitals, with distributors, and he has founded internationally recognized consulting groups. He, in fact, has been with a consulting firm for the last 30 years that has been helping over 1,700 hospitals and 180 IDN clients. Jamie's the co-founder and the founding board chairman of the Bellwether League, which is the not-for-profit Hall of Fame for healthcare supply chain leaders. He's also been selected by ARM for the 2011 George R. Gossett Leadership Award, which is the ARM organization's highest honor. It's my pleasure to introduce you to Jamie Kowalski today, and Jamie, I'll go ahead and get things turned over to you.
Thank you very much, Cheryl. Thank you to Jump Technologies. Thank you all for taking the time, as Cheryl indicated, out of your very busy schedules to join me in what I hope to be is a valuable and productive message to you. I've been looking at this topic for quite some time and realized that technology is certainly playing a greater role in supply chain management, and we'll discuss how that is kind of coming about and what you might be thinking about, or maybe could or should be thinking about it as you go forward. And what I'll do is I'll cover this by, first of all, defining what I'm referring to, at least, as supply chain management, because if you put us all in a room and we were face-to-face and we all said, here's my definition, we'd probably have 30 different definitions of supply chain management. So I want to get us all on the same platform as we talk about supply chain. We'll cover some of the objectives very briefly, and we'll talk about some of the information, challenges, and requirements. And that's going to be a very quick look at this. We're not going to delve deeply into all of these aspects of supply chain. And Cheryl indicated I would walk you through this. We'll probably be sprinting at that point during the presentation. And then we're going to talk about the actual technology that's out there. What are some of the things to be looking for? So I guess the only thing I could say at this point is buckle up and hang on, because we're about to move to into the program. And let's start with defining the actual term supply chain. And I take liberty with this. I guess maybe in agreement with many people in this profession, in this industry, but maybe not so. And if not, I'll try to defend why I'm saying this. But I believe supply chain management in a healthcare provider organization is not unlike in any other enterprise. It is broad-based. It is comprehensive. And if you look at this diagram that we put together for you in these beautiful colors, is something that starts at the very beginning and goes all the way to the point of use. So in some hospitals, supply chain is considered the department of supply chain, which sometimes is purchasing and contracting, receiving, storeroom, and maybe a few other things. But supply chain is more like a management discipline is what I'm trying to get at. And if you looked at it, even from an activity-based cost view, as to where the costs are associated with supply chain management in a provider, it's all of these elements from when you start to determine what it is you need. What are the products? What are the equipment items? What are the services? And you follow that step in that process, rather follow that step with the process that we show here in this diagram. You get all the way to the delivery point. I hope you will agree that there are many players in the supply chain that are not a part of the official supply chain or that report to the supply chain department or the officer or manager of the supply chain system. You have people in pharmacy. You have people in engineering, biomedical engineering, food service, housekeeping, plant engineering, where it might be buildings and grounds. They play a role in the supply chain, and so do the clinicians. Surgery is a good example. They have their own microcosm of the supply chain, and frankly, it's a pretty big supply chain. So when you look at it and you want to look at optimizing, you have to consider it in a holistic way, end to end. Regardless of who's doing it, it's the process. And again, those parties, those resources that are associated with it. And I hope you will agree that in most organizations, that is a multi-part, multiplayer type of system. Now, if we look at the next slide, I think that hopefully will gain your attention as well, is that research that when I was with Owens & Minor for 4 years, we looked at some research that was done by others, HFMA being one of them. S&P Industry Surveys was another one. They came up with the pro forma, literally, the projection that the total annual costs of operating the supply chain as defined broadly, not the spending on just the goods, not the people and the other expenses associated with the department of supply chain, that total cost enterprise-wide reaches 50% of the annual operating expenses of a provider organization. Single hospital, IDN, doesn't matter. Now, since 2008, there hasn't been a follow-up study like this, but there have been individual IDNs, for example, that have done their own analysis and report that, yes, they are right within spitting distance of 50%. They might be 48, 49%, or 51, 52%. So plus or minus a couple of percent, that's what they're finding when you add all the pieces up. Now, when you do that, and you look at the supply chain as a part of the provider enterprise, particularly in large IDNs, and some of our IDNs, as everybody knows, are getting really big, 50, 60, 80 plus hospitals, not counting the clinics and the ambulatory surge centers that are part of supply chain and that are part of the supply chain, both the customer part of it as well as the operator part of it. We're talking about supply chains that are as big as many of the Fortune 500 companies. Billions of dollars associated with that. Billions, multiple billions of dollars. So I just want to make the point that I'm looking at the big picture, defining it very broadly, but I believe in an accurate way, particularly when you're going to talk about, well, how do we go about optimizing supply chain? You need to know what it is you're defining. And I think in order to optimize, you have to include all the components, all of the people, all of the processes to get those kinds of positive outcomes and benefit to the bottom line. So let's look at a couple of these opportunities, and these are the ones I'm going to go through a little quickly so we can get to the technology discussion itself. These, you might say, Jamie, I'm not hearing anything new. I'm just trying to package them in a way that they fit together, and you can see a total picture as far as what can be looked at as far as opportunities in supply chain and optimizing those opportunities. And the first one that comes to mind is spend management. You know, if you're an organization that's spending 20, 22, 24, 25% of your dollars on supplies and goods and services, you better be managing that pretty closely. And some of that management comes about through better, more accurate, more visible budget development. And the accuracy comes on appropriately allocating the cost of supplies or identifying where those costs are. Make sure you have them all related to supply chain, and particularly the products, and what budget they're going into. I still find hospitals that are allocating supply costs to central sterile or central supply, whichever you want to call it, that really are used through and by surgery. Well, why aren't they allocated to the surgery cost center? I don't know. In some cases, I don't get a very good answer. It's just sort of, well, we've always done it that way. Trying to set up an encumbrance system so someone who is trying to manage a departmental supply budget can know right then and there whether or not they have the money in their budget to place a requisition, which will become an order, which will become an invoice. If you knew up front, you might do something differently. And without that immediate feedback, you just don't know. You might find out 3 weeks, well, I'm sorry, probably 4 weeks to 6 weeks later, after the books are closed for that particular time period. Consuming excess inventory, we'll talk about inventory a little bit more. That's one way to slow down spending. And then applying value analysis, and we'll get into that a little bit more too. You have to have analytics and the right metrics so that you can drill down all the way to the second column with the 3 P's, that's P as in Paul, procedure, patient, and physician. That's what's been called the Holy Grail, and sometimes that will be dependent upon the maturity and the capability of your electronic medical record or your electronic health record, whichever you want to call it, to track and capture spend by physician, by the patient, and by the type of procedure. So that when a hospital is trying to determine whether or not they're making any money on any of those procedures, or by employing or allowing these physicians to practice in their hospitals, that data has to be put together and matched up and done on a regular basis and on an automated basis. If you try to do it manually, it'll take so many months that it'll be old news and no one will bother to do anything with it. So you want to have the metrics there driven by accurately and timely development of and capturing of the data itself. Let's look at value analysis for just a minute. Value analysis is, in my definition, a process by which you meet but don't exceed the outcome requirements, and it parallels pharmaceuticals and drugs very closely, except that we don't have data on products like that is available through the FDA, etc., for drugs. We can't tell for sure that product A, B, and C are absolutely identical in terms of their outcome that they achieve. So in the case of pharmaceuticals, you have aspirin, which reduces fever. Okay, you have other products which reduce fever, and those have been tested in independent or quasi-independent labs to determine that. We don't have that, so we do the best we can with supply items. But if the theme or the objective is to meet but not exceed, we'll avoid unnecessary bells and whistles. We'll avoid the issue of, or be better able to avoid, the issue of, well, I'm a physician who went to school at XYZ University, and this is what we use there, so I'm not going to use anything differently ever again. So don't ask me, because my preference is X. Well, you have a better opportunity if you say, doctor, please describe your outcome requirements and even quantify them if possible. Data is going to drive this. And again, data is going to come from technology. There are best practices that are out there. We ought to be finding those, and maybe some of the things that I'm hearing the Cleveland Clinic is doing, and if there's someone from the Cleveland Clinic on the line, I think the important thing is that they're out there. We could copy what they're doing and maybe not go through this entire process for each and every hospital. That may be politically untenable, but at least it's something you could consider. Let's look at the next one where we're talking about sourcing and contracting. In that one, you'll notice the first bullet is that it's value analysis driven and coordinated. So we just don't go out searching for items. We hope that this is something that the value analysis process will present to the sourcing and contracting process. So you're buying things that meet but don't exceed the needs of the individual patient or et cetera, department, physician maybe. Much of sourcing and contracting would be best, as we've seen, best practice centralized. Again, do you want your clinicians, nurses or other, to be doing some sort of contracting or negotiating contracts when they have not been professionally trained or educated and or have the tools to do it? It seemed to me that if I have clinicians, I want them doing clinical work. They need a role. They need to tell us what they need through the value analysis process, but then let the supply chain do what it needs to do. Okay? So relative to group purchasing, let's talk about this. Group purchasing is evolving as we speak. Some of them have become for-profit, publicly owned companies. There are alternatives that are being developed nationwide. There's over 50 around the country, what are called consolidated service centers, which is a way of centralizing and taking the contracting and procurement of business from the GPOs and doing it all in a self-contracting, self-procurement model, which frequently includes self-distribution. There are many players out there. As I said, there's over 50 in the U.S. and another couple dozen in Canada. So this is not a fledgling thing. This is some very large enterprises that are doing this. Then you have the collaboratives that are being formed primarily as a result of linkages through clinical programs, which frequently are high supply spend clinical programs, but they are common in the organizations that are a part of this collaborative, and it's driving some of the contracting there. We're going to buy orthopedic, cardiac care, whatever it might be, products all together, and we're going to combine our volume. We're going to standardize, which obviously goes back to value analysis, so that these organizations are willing and able to do that on a good, sound footing. And some of this is now coming from insurance companies that are saying, I know what I'm paying the hospitals for this. I want to find out what they are spending on it, and I want to see if I can drive, I, meaning the insurance company, drive ways to drive down the cost of those items so I save money, and hopefully, eventually, my covered lives, or the people that I insure, save money and lower premiums if it gets down that far. So the whole concept of contracting and sourcing, particularly through groups, well, groups, not group purchasing organizations, but groups such as these collaboratives or CSEs are coming from a variety of models. I just want to share that with you because some of them are having some extremely powerful results and some great successes. So keep that in mind as you consider what might be out there that might be coming your way or that you might be involved with right now. All right, let's look real quickly at inventory management. I said we would come to it. I push very hard to get people to agree that the concept of inventory management needs to be looked at as inventory is the same as cash. You don't buy inventory, you keep the cash in the checking account or wherever you're keeping it. And that's important because the cash situation in many, many hospitals has deteriorated significantly. And that's something that might be involved, might be being considered with bond ratings and other factors that hospitals are dealing with relative to their overall financial position. Inventory has a visibility problem. It's out there, Many times it's already been, I'll say, distributed, and the cost of that inventory has been already allocated to cost centers, so it's no longer in the inventory account in the balance sheet or on the balance sheet, but it's still there. And some of that, as you all know, is unconsumed for weeks and frequently months and unfortunately sometimes years. Well, to me, that's not inventory, or rather that's not an expense because it didn't get used in the period in which it was expensed, if you want to be a strict accountant. I'm not an accountant, but I had enough accounting courses in college to make myself dangerous, I guess. Hard to hold people accountable for that if you don't know where it is and how much actually exists. That's unconsumed goods that are still stored somewhere is what I'm calling inventory. So how you define it is really important. If you're only defining it as what's on the general ledger, you're going to have a very minimalist and narrow view of what the value of the inventory is. Now there's another factor, and accuracy and accountability comes into this that you might not be aware of. Not that long ago, the government established a ruling, or did a ruling that said that the accuracy of the financial statements must be personally validated by the CEO and the CFO of the organization. That means they're personally accountable, which means that when they sign that financial statement, quarterly or whenever, however often it might be, if the inventory is understated or overstated for that matter, those financial statements are not accurate. And if I were a CEO and CFO that had to put their name on a document and I was going to be personally held responsible, I darn well better be sure that what we're calling inventory is the right definition and how we are handling it and holding the rest of the organization accountable for their part in the management of that inventory. That's pretty darn important. Inventory management is important for demand planning. You're seeing more articles, more presentations at conferences where people are talking about the benefits associated with more sophisticated demand planning. That goes beyond par levels. You could argue par levels is a very rudimentary type of demand planning, but we want to get the suppliers in the loop so that they can do some demand planning for their purchase of raw materials and production. That's where you really are going to optimize things, is when you get everybody in the loop so that they can contribute to this. And then I guess the last part of this is it allows standardization of product, price, and supplier. So if you look at your inventory and really find out what's out there, you might be surprised at how many different suppliers or how many different products are serving the same basic need for quality of care, clinical care, or basic operations in other departments. So those are some of the opportunities and some of the things that are occurring right now in inventory management. Let's switch over to what I'll call operations. And we're talking about how do we optimize those operations? Well, many are going to Lean Six Sigma approaches, and that's good. Some are back in the 90s and the 2000s dealing with re-engineering, if I can use that phrase, or just operation performance enhancement or something like that. Doesn't matter what you call it, doesn't matter what tools you use, you're trying to make the processes, those that are the ones that need to be followed, and design them in a way that they can be executed as efficiently as possible. Now, if you have nurses doing a lot of supply chain tasks, you have not optimized your operations in supply chain. If they're the ones counting, if they're the ones completing a requisition, if they're the ones that are putting products away, if they're the ones on the phone trying to track down an item that they need, that's not efficient. It's way short of optimization. And I will tell you this, I was involved with doing a survey in 2009 where 1,600 critical care nurses, that includes OR, and nurse executives, filled out a survey that said, and 70% of them answered that 20% of their shift, every shift they work, every day, that could be an 8-hour shift, 10-hour shift, some hospitals have a 12-hour shift. It's spent on supply chain tasks, and the biggest task is searching for supplies. If that's what your nurses are doing, and there's a high probability they're doing that maybe not to that extent, maybe not 20% of their shift, but if they're doing it 10% of their shift, that's 10% they're not nursing. And if that's the case, they are not happy, they are getting burned out, and you're wasting the dollars you spend on their compensation. So that's a really important element. Obviously, you want to look at whether or not automation can come into place. Some of that might be manual, or some of it, rather it's manual versus automation. Some of that might literally mean robotics when picking orders in a very large storage area, such as a warehouse or a distribution center, and other types of automation, such as not hand cleaning certain items in sterile processing. Maybe there's equipment that can do that quicker and better than you can do manually. So it's looking at those things. And then it's also consolidating and standardizing the processes. So if somebody is doing the task in the OR, in pharmacy, in engineering, or whatever, excuse me, can that be standardized? Can that be automated? Now, maybe in one department it doesn't make sense to automate it, but maybe if multiple departments are going to use this and multiple people, and that's going to have a bigger impact on the enterprise, maybe that's something you ought to be looking at, is what is the automated method? And that could, again, be information technology instead of doing something manual. All right? So think about that. Now, again, I apologize if we're moving quickly here, but we want to spend a little more time talking about the actual technology aspects of it. All right, I touched a little bit on metrics. Metrics really are there to define and track performance and value. So they need to be multifaceted. And I, like yourselves, I have heard many CFOs and CEOs say, I just want one metric for supply chain. Tell me what the one metric is that I can know whether or not my supply chain is operating correctly. Now, in my introduction, you may have gotten the sense that I actually worked for 1,700 hospitals and 180 IDNs. No, I'm not that old. I've been around for a long time, but not old enough to do that. But that many organizations have been my clients over the years. And I can tell you that that is a frequent question and phenomenon. And in my own efforts and in efforts of many of my competitors and my colleagues and my clients, no one has been able to define one metric for the supply chain, because there are qualitative aspects, there are quantitative aspects, and some of those quantitative aspects are financial, others are productive, others are service level. So you can't do it. And any organization that says to you, oh yes you can, this is a good indicator of supply chain performance, I would challenge that. I personally challenge that. I don't believe it. That's not been what others and I and myself have found. So I think you've got to make sure that you have the right items that you're measuring, and you're measuring proverbially what matters, and frankly what can be managed. If you're worried about your overhead allocation for heating and air conditioning, or for the lights or other electrical costs, don't, because you can't control that. You can't manage that as a part of supply chain management. Now, maybe the engineering department can, or the facilities department can manage that, but you can't. So deal with the things that can be managed, that matter to you, matter to the enterprise, matter to your customers, and frankly, your business partners, aka suppliers. So maybe you need to be measuring those things, tracking them, and then, as the bottom bullet says, you're taking action. If you're just measuring it and putting up fancy charts and nice colors and everything else, it's meaningless. People have to understand what it means, and if you're tracking at the wrong pace and maybe in the wrong direction, that you have an action plan and you execute the action plan so that the metrics turn out to be better than they were the last time. Benchmarking is simply comparing the metrics from one organization to another, or from your own organization to maybe your organization's performance from a previous time. So benchmarks are really not metrics. Benchmarks use metrics. So I just want to clarify that. So you have a variety of metrics that can be used at various levels. You have the senior executive level, CEO, CFO, who are looking for one, but maybe if you give them 6, they'll agree with that, particularly if you keep it on one page. That there's a little bit of a joke there. If there are any CEOs and CFOs on the call, I apologize for any offense. But my point is, keep it concise. You can't give them everybody's picking accuracy or everybody's picking performance on a number of lines picked per hour or anything like that. That's not an executive level metric. So be careful that you match the metrics to the level of those needed by the types of individuals that you're going to share this information with. And do share it. Don't hide it in your own office. You have to share it with the staff, give them feedback, and give your customers feedback. And if nursing says, we're always running out of this item, you have a metric or a way to track that and demonstrate whether or not they are correct or you are correct, or maybe you're somewhere in the middle and some corrective action or some change needs to take place, like demand planning, possibly. Okay, so let's move on to the clinical opportunities and talk about those for just a minute. All right, we talked a little bit about the use of the nurse. I believe that they are best placed in the supply chain where they have a role in value analysis, which defines what it is that ought to be used, ought to be purchased, and maintained at whatever utilization volume levels, but not in the tasks of supply chain management, unless somebody like the surgery department or cardiac cath lab or maybe the ED or whatever might say, well, we want to manage our inventories. Okay, if they do that, they take that on, and to some degree, you're off the hook. I don't like that. I'd rather the supply chain people be the ones to do it because they're the ones trained to do it and the ones that can be focused on it and the ones that have the tools to do it. So if they want to do that, fine, but we need to point out to everybody what that means and whether or not they're really going to be able to accomplish it. If you can focus them on their valuable input in the value analysis process, I think you're going to be much further ahead than if you have them managing their own inventory, placing their own orders, all of those activities. Surgery, by the way, is not an exception to this concept. And by the way, as I said, they contributed to that survey in 2009, and surgery nurses and executives or managers said they don't want to be in the supply chain management business, but they do it because they don't trust that they will get what they need when they need it and will be able to find it. It won't just be somewhere in their department. They'll know where it is all the time. And I'm sorry if that's a condescending remark to anybody on this call that, hey, wait a minute, we do a good job of supporting surgery. Ladies and gentlemen, I will tell you that's what they said. Now, maybe you could argue, well, that's 6 years ago, and that may be true. Whether or not we will do a follow-up survey pretty darn quickly here, I'm still weighing that right now. But I think it's important to know that even further interviews that I've had with nurses and nurse executives in surgery admit that they do it because they don't think anybody else can do it as well. And they do not want to be left with their hands open and the product not available, particularly if they're going to get in trouble for it or be yelled at or worse. So they're doing it themselves for that reason, not because they want to. And frankly, not because they can do better than trained supply chain professionals and a good, well-operated supply chain system. Okay? So let's go into the last one before we get into technology, and that's physician engagement. And it really boils down to this. You want them involved in the value analysis process. Frankly, you want them in the thick of the value analysis process. Their input is going to be extremely valuable, and now that they're employees, it may be different than for those who are free agents and utilizing the hospital, bringing business to the hospital. And I'm hearing that across the country. That is, in fact, happening. But if you do not have data that is timely, accurate, and relevant to what the physicians are going to be interested in and what those physicians can change or manage or do something about, you're not going to get anywhere. And like I said, I said earlier, if you do a manual process analysis, and it takes 6 weeks, 8 weeks, and it could, to do all the analysis, to get down to one procedure by physician, by a variety of patients, you're going to end up not having timely data, and if it isn't timely, physicians can easily say, therefore it's inaccurate and worthless. Let's not even bother to take the time to talk about it and get our blood pressure up if we don't agree, if that's the source of the data that you're going to provide for our conversation. It better be accurate. How are you going to get that? Well, we're going to get to it in just a minute, and that is technology and the ability to automate the process to gather, analyze, and display that information that came from data. So, yes, they need to be doing all those things. So let's talk about the technology solutions. Before we switch to a page that might be a little bit of an eye-opener or a blinder, we'll talk about it conceptually. We have so many components of the supply chain that are being utilized or being affected by a variety of people, departments across a healthcare provider, hospital, IDN, etc. You have different ERPs, and some of those ERPs do some things that are basic, some things that are a little more advanced in supply chain management. Others don't. So that will vary. That's a variable that you're going to be dealing with, is how robust is the ERP, the hospital financial system, as far as analyzing data, timely processing of data, so I can do inquiries and analysis on a spot basis or even on my own schedule, not just on the financial system schedule. Certainly, technology is an enabler, and the bolt-ons, as they have been referred to, in my experience and in my view, based on analysis, based on observation, based on interviews and my clients over the years, a lot of the bolt-ons are really now essential. And I'm speaking of specifically, and if I blatantly give them a little bit of buzz, I intend to do that, like our sponsor, Jump Technologies. They have systems that enhance what the ERPs are doing. And others have those as well, and we're going to get to that when we get to the next slide. But you need real-time visibility all the way to the point of use, and that includes what inventory is on hand at what time. So as I said earlier about inventory visibility, the accuracy of the financial statements, the ability to do demand planning. If you want to optimize the supply chain operationally, you have to have this data. You have to have it in an accurate way, in a timely way, and in a way that you don't have to ask for 17 additional FTEs, because you're not going to get them. I don't even know that you'll get them if you make a great business case. So you really have to have the ability to do the in-depth analysis and do what you can through that to get to that performance level that you need. If you're good, you need to be better. So even if you're good and you're in the 90th percentile, the good 90th percentile, not the top rather than the bottom, you definitely want to make sure that you continue to progress. And you may never get to me. Probably theoretically it's not even possible to get to 100%, but if you could get there, that's where you want to be trying to go every single time period that you look at this. And you have to invest to get a return. But now that you have these bolt-ons that are now becoming essentials, that are cloud-based, that are not, that don't require you to invest $500,000, $750,000, $2 million, or whatever, in technology licensing fees, you're in a better position to actually be able to access them financially. So that's a good way of positioning it, but you better create the business case that says we can get a return even if we have to invest in a monthly payment versus a one-time or an annual, excuse me, licensing fee. So it seems to me that the technology that 5 years ago, 7 years ago, was out of reach of so many organizations, so many provider organizations relative to, supply chain management. It's really important to be able to say, hey, we can do this, and we're going to get some great benefit out of it if we do. And we don't have to dip into the capital pool. We can do it through the return we're getting as we go along. So keep that in mind as you look at some of these opportunities. Now I'm about to reveal, can we have a drum roll, please? The slide that will look way too busy and you might even argue with, but it's an attempt. It's an attempt to put on a visual image that definition of the supply chain. If you'll notice, we have circles rather than links in a chain because we needed to be able to fit everything on the page of the components of the supply chain. Now remember, this is the supply chain enterprise-wide, which means all of the people doing these types of transactions or contributing to it or processing these types of transactions, they are part of supply chain management in this image. So please keep that in mind. If you look at the blue circles around the light green circle in the center, there are all these white rectangles with black font. And what those rectangles and squares are supposed to provide to you is a generic definition of technology that can enable and enhance and help get toward optimization of that component of the supply chain. We're not going to go through every one of these and discuss them individually. I might just point out a couple for purposes of illustration here for this presentation. And I'm sorry we're not in a room where, excuse me, we could actually have a discussion. So I'm going to try to provide some of that with my illustration and remarks. But if you do have questions, please go to the chat and fill those out, and we'll try to get to them either as we go along or we're getting close to the end of my presentation part. We can cover it before we end today. But look at, and I talked about inventory management, for example. So if you look at what would be about 11 o'clock on a clock, the inventory management square. What do you want to do? Well, you want to manage demand. You want to be able to forecast. You want to be able to determine the total cost per encounter. You want to be making sure that you have quality. I'm sorry, I'm looking at the using square. Switch gears for just a minute. In order to manage use and spend, the one right next to it, you have to have the ability to do all of these things. Really manage demand, understand what it is, be able to forecast, etc., so that you can match that up with use, so that you don't have to accumulate much inventory, even though you are a hospital, even though a hospital has a human being as an outcome, either repairing that human being who has been severely traumatized or making them well again if they have an illness or both. You want to be able to look at all of these components, be able to do it virtually real time so that you can take corrective action. Now jump down to what would be about 5 o'clock, and that's managing inventory down there. And we have two squares because we couldn't fit it all in one. So you're talking about, yes, utilizing the ERP, sure, but do you have a data cleansing tool that will take your item master file and manage it, normalize it so that your descriptors and all the other data elements are standardized? They are in the appropriate position in the actual definition. They can be cross-referenced, and it's all the same. If you don't have that, you're not going to be able to fully utilize even your item master very well. You want to have the ability to use the analytics that look at inventory and look at usage, look at peak usage, look at off-peak usage, look at the mean, the median usage, and try to determine appropriate safety stock levels mathematically, rather than by saying, well, you know what, I think we ought to keep 2 extra on hand just as safety stock. Well, that may be good, might be good enough, and you might be good and or lucky, or both, in terms of your estimate that that's what the number ought to be. It would be even better if you use the mathematical formulas that are available, and you can apply that to healthcare. All you have to do is adjust the mathematical components and account for those. You want to do this at the point of use. You want to do it everywhere inventory is suspected to be and or is known to be, and that's really important. You want to have tools that will help you with doing physical counts. Those are awful. When they're done manually, they take tons of time. They're very expensive. There are tools now that allow you to do that. I'm not talking about a count to replenish a par level. I'm talking about the fiscal year end or the quarterly or monthly cycle counts. You need inventory management to appropriately handle recalls. How are you doing that? excuse me again, do you have that information? Are you using it to rotate items and to watch out for the expiration dates? Can you track mobile equipment with some sort of an inventory system? And even to do your basic par level management and analysis. There are so many tools, and I will suggest to you, I think you will all agree, that your ERP alone can't do all that for you. You do need other tools. So I'm not dissing the ERPs by any means. I'm saying they are designed to do something, and it's not to be a tool that helps you completely optimize your supply chain. It is there to do a component thereof, particularly those that directly affect the financial statements. There are some components that of inventory management that do not directly affect the financial statement, but you need it to manage it on behalf of your customers and fulfilling their demand and their need every time that need occurs. There are systems now, if you go to 7 o'clock on there, I guess we don't have a 6 o'clock exactly, WMS, storage and warehousing, warehouse management systems. If you are in an organization that has a warehouse, has a shared warehouse or a consolidated warehouse where multiple facilities are getting their products from that facility, you're going to want to have a warehouse management system. You're not going to want to try to use your ERP to manage that size and that complexity of an operation. I've seen it. I've studied the 47 consolidated service center models in the United States. They can't get it done with the ERP. They've all said, we need a WMS, a warehouse management system. Okay, fine. That's a heads up for all of you that maybe are not doing it and maybe are not totally satisfied with your performance, or that are using it, but you're not quite there either, and maybe you could be doing more or better than that. Same thing for record storage. If you're going to use part of a facility like that to keep record storage, you better have a library system that allows you to find, deliver, return, and then periodically purge the records. I'm sure you all have the experience of having gone to a third-party records management company and you discover that the purging hasn't taken place on a regular basis. You might have boxes of files and other documents that go back 20 years. Check with the requirements, but many of those are no longer needed, and it's going to cost you a ton of money to purge them. So this may actually help you do some of that. And then let's take a look at value analysis. And that's related to spend analytics, obviously, because your value analysis, you want to target things rather than just react to opportunities. I want to look at the spend that I have in urologicals. What is the item that I spend the most money on? What supplier do I spend the most money with? Are there opportunities there for standardization in urologicals? Because I have 6 hospitals in my IDN, and 3 of them use one supplier or one product, and others use something else. Well, you're going to be able to drive value analysis by giving the data to the group or the teams that do the value analysis for your organization. If you don't have that information, you will likely be limited to reacting. In other words, somebody comes in with a new product and says, hey, what do you think about this? Looks like we could save some money here. You're going to be very reactionary. If you want to be proactive, you need to be analyzing data that's, again, accurate and is timely and something you can do something about. And I think value analysis would be another one. So I'm going to stop my illustrations here and see what kind of questions we might be able to take in the last few minutes from the audience. I'll be looking for, Cheryl, if you have any that you want to send over to me, or audience, if you haven't done anything now and you want to challenge anything that I've said, and I'm open for that. It's hard to do this electronically rather than verbally, but I'm happy to take that question that might be a challenge, or if you have a clarification question that you'd like to, because in the very last slide here, to wrap this up, the question is, do you have the best possible? And if you look at these components, this is what drives optimization in supply chain. The quality of the leadership, is there a strategic plan, executive engagement and participation in supply chain management, the education of all the managers, the physicians, the staff throughout the enterprise, not just the supply chain employees. The organization of supply chain. Are there connections between what pharmacy and clinical engineering are doing and the supply chain operation? Your business partner relationships and how they're being managed. Obviously, the technology tools, the thing we've been focusing on the last several minutes, your metrics, and last but definitely not least, patient safety, patient service, patient satisfaction, quality of care. That's what that boils down to. So the technology tools are enablers. They're not ends to themselves, but they should enable better performance in supply chain management. There are so many out there that you could be looking at that would help you in that endeavor. And I would encourage you to take a look at those, assess what your needs are, evaluate that objectively and quantitatively if you can. And if you find a solution that you think is going to bring you a positive return on investment, draft the business case, take it to whoever needs to be reviewing it, and get on the list to say, look, we need to invest in this, or we need to add this to our operating budget, but we'll be getting some savings to offset that and hopefully exceed the cost of that tool, whatever that might be. And each tool needs to be evaluated, A, for its own individual contribution to your savings and expense reduction, as well as maybe complementary benefits to you. If you have these two tools, even though they might be from two different companies, they may allow you to do better in some aspect of supply chain combined than you could do with either one of them themselves. So let me leave it at that and say, please get help if you need it, to identify what your needs are, your opportunities are, and how to put together the business case. Are there any questions that you want to throw here?
Jamie, it's Cheryl. I got a question from a person asking about integration. And so one of the challenges when you have the systems you referred to as bolt-on systems is that there's inevitably data that you need to share back with or push back into your ERP system. Are you seeing models where there's successful integration between the bolt-on solution and the ERP?
Yes, is the quick answer. The extended answer is this too. Some of the ERPs and the bolt-ons have gotten together and built the interfaces to fully integrate them that way. Some of the tools out there actually, I'll use a very sort of a rudimentary description here, but sit on top of the disparate technology systems, bring that data together, normalize it and standardize it, whatever, and then feed it back in through your ERP or wherever else it needs to go. They're out there right now, and they've been used in other industries. Because some of those industries, I mean, think of the companies that acquire some other company. Well, they have disparate ERPs probably, and probably disparate supply chain tools. Somehow they don't want to just throw them all out and start all over again. And not only that, that'll take so long that you'll lose some of the opportunity for saving money. And every day you don't save $10,000, or every year you don't save $1 million, and you drop that down to a daily base, whatever that is, ladies and gentlemen, you're leaving money on the table. Money you can't afford right now, particularly with reform and the changes in reimbursement, et cetera. So, yes, they're out there, and you have to find them, but they're out there, and they do work. I've seen that, and not just seen it from the supplier of those services. I've seen it from their customers that are actually utilizing those services. Hopefully that answers the question. Any others?
I haven't seen any others via chat. If anyone has any additional questions, please send them in via the chat link right now. Jamie, thank you. If there are no other questions, thank you so much for your time. I did want to let people know that Jump Technologies will be offering 2 product education webinars in the next week, one on inventory management processes and one on improving receiving and tracking processes. And for folks that joined us today on the call, I'll go ahead and send out registration links to those 2 sessions that are coming up, one on Friday and one next Wednesday. If you have any questions for Jamie, please, I think that Jamie would be very very pleased to hear questions from you. Jamie, I took the liberty of putting your website up here on
Sure.
this slide. If anyone needs to be able to reach Jamie directly, please just let me know and I'd be happy to get you in touch with Jamie. And then if you have any questions for Jump Technologies, you're more than welcome to email me directly at cfleury@jumptech.com or visit our website or give us a call anytime. In the meantime, I would like to thank Jamie so much for your presentation today. Jamie, you did a wonderful job of a very complex topic and breaking it down into some manageable sections and components. So thank you so much for your time today. And again, if anyone has any follow-up questions, please don't hesitate to reach out to us. Thank you for your time.
Thank you, Cheryl. And by the way, real quickly, before we close, I've dumped a lot on you here in a rather short period of time. It's a lot to sort through, but take it piece at a time, but then keep the big picture in mind. As I said, get the help if you need it, and I wish you all the best of luck. Thank you.
Thanks, Jamie. Thank you, everyone, for joining us today.